E ngā mana, e ngā reo, e ngā iwi, tēnā koutou katoa, ki te whare o te papa o Tongarewa, tēnā koe, Murray, tēnā koe, ngā mihi nui ki a koe, Ian, swim down the back, tēnā koe, kia ora koutou katoa. It's great to be here this morning. Thank you very much. So yes, I'm Ashley Bloomfield. I'm 5.5 months into being the Director General of Health, and I just want to start by saying I consider it and am finding it's a great privilege to be in the Ministry of Health, back in the Ministry of Health and working in this role. Look, thanks very much for the invitation. And Murray, yes, I am happy to take questions, although some of you will know I was in here yesterday afternoon to listen to the Minister's speech and in particular to the questions he got to make sure I was lined up and wasn't saying anything contradictory in response to what he said. So I was thrilled to hear his response to the first question was, well, the Director General will be in here tomorrow and I suggest you give him a good grilling. So suffice to say I wasn't in a position to take him to task over that afterwards, but I don't have anyone I can defer my questions to, so I will do my best to respond when we get to that point in time. So, look, a number of you in the room I know and have worked with you either in the Ministry of Health or out in the sector, or indeed if Clinton Pinto's still here, we trained together at medical school. So some of you are unfamiliar, but it's great to see you here, and I look forward to furthering the relationship with you individually and also with your organisation. I have spent my career in the public health system in a range of roles. Was fortunate enough to have 1 year away at the WHO in Geneva working on non-communicable disease prevention control, which is my area of professional interest. And if any of you know me over the years, the area of tobacco control in particular, but also diet, physical activity, alcohol and drug policy are areas of particular interest. So I had about a 12-year stint in the Ministry of Health previously in a range of roles, and I started off in what I'd call technical professional roles, and somehow I ended up going down this pathway of executive leadership with some wonderful coaching, support and mentoring from people like Dr. Don Matheson, Stephen McKernan when he was Chief Executive, who's remained a really close sponsor really of me as I've gone through my career. And as you all know, he had a stint in the ministry just before I did acting, and I've tried in a number of areas to continue the good work that he had got underway there. So I spoke last week, I was down on Friday in Canterbury actually, and spoke to the group of clinical leaders down there that have got a really well-functioning and good oversight arrangement around the build that's happening there, and I think they do a number of other bits of work. But the first question someone asked me was, well, who's the Director General? What is this role? What do you do? So I thought I'd just make a couple of comments on that. I see my role, I wish it only had 3 parts, but there are 3 main parts. The first is, of course, to be the point person in the relationship between the Ministry of Health and the Minister and Associate Ministers of Health and the wider government. So we're the Ministers and the Government's chief policy advisors really around health, and that's a role we have to and do take very seriously. So I have a lot of interaction with the Minister, and you'll have seen him in action both yesterday and a year ago and in other settings probably, and I dare say he's a very committed and engaged Minister, and for someone like me who's spent their career in the public health system and who has trained in public health, when your Minister's list of priorities are equity, a strong publicly funded healthcare system, mental health and addiction, primary healthcare, child wellbeing, not exclusively, but that's a bit of a dream list of priorities actually, and I think it's a great opportunity for us all to support him and this government to deliver on those aspirations. So the second part of the role is leading what is quite a big organisation. So my full title is Director General of Health and Chief Executive of the Ministry of Health. So we're an organisation of about 1,200 people in a whole range of roles, and we cover a large number of functions, not just those really core policy and regulatory functions, but obviously the health sector is a large, complex undertaking, and we're responsible for providing, I guess, stewardship and leadership of the sector. And of course that leadership is not a command and control leadership, it's a convene and collaborate leadership, because you know as well as I do that the health sector does not work in a command and control way. it is about convening and collaborating. And I think this is a point of difference between the health sector and most, if not all, of the other large operational sectors run out of government. If you think of corrections, if you think of even social development and work and income, there's a very direct line of sight from the chief executive right down to the office or shop floor. That's not the case in health. It's a much more complex and organic system, and I think this is something that perhaps other parts of government don't always appreciate fully. So that segues then into the third part of the role, which is that leading the organisation as a part of the health sector. And the health sector relies on a strong, effective, really capable Ministry of Health to be able to deliver everything we need to deliver for our citizens. And so the way we engage and work with the wider sector from the clinical interface, from service users, consumers, through the clinical interface right through organisations is really critical to both our effectiveness and to the delivery of really good health outcomes and equitable health outcomes for New Zealanders. So there are the other three broad parts of the role, and I've touched in there on those, and I've mentioned the word leadership and the words leadership and stewardship in there, and as chief executives usually do, and usually with good reason, coming into the organisation, I have done a bit of a shift around, probably understating it by saying a bit of a shift around. It's quite a significant shift around. However, that was predicated on us being able to better deliver those leadership and stewardship roles for the sector, to be able to lead in a way that is around convening and collaborate, which is deeply engaged. And I have a really simple definition of leadership. Leadership is about ensuring direction. Now, that's not giving direction, they're different things. It's about ensuring direction. It's about generating energy, and you get focus and commitment, and you deliver stuff. And then the other role is the stewardship role, and that's about having a longer term view of actually we can both improve the sector now, but we've got to set it up to be sustainable and to be able to deliver for New Zealanders into the future. So we need to have a really deep understanding of what the population health needs are going to be in the future, in particular how we better address the needs of populations that are not getting what they need. We need to have a deep understanding of and really clear strategy around workforce, around data and digital developments, around infrastructure, and the Minister spent quite a bit of time yesterday talking about the physical infrastructure in our health system and the real challenge there is there. We should have a really clear view of how all those building blocks need to come together or continue to be progressed strategically to deliver on that future health system. So that's the stewardship function. I've talked a bit about, I started to talk about the Ministry of Health changes sort of in the leadership and structure of the ministry, and part of that was because my sense was coming into the ministry that it didn't feel like a health organisation. It looked quite generic in the way that it was structured and in the titles of the different parts of the ministry. So I guess I'm a bit of a traditionalist. I started in the ministry in 1997, so I've been through a number of iterations of the ministry. However, the new structure is designed to in part, reflect how the sector organises itself. So you can look in, if you work in the mental health and addiction sector, and see there's a mental health and addiction directorate. There's a disability directorate. This is about $2 billion worth of funding that we commission directly out of the ministry, so it's a big budget on disability services. You need someone around the executive table who's leading that area. There is a workforce directorate, and that's a very deliberate decision to establish a workforce directorate, because I think that's an area we need to collectively do better in, and obviously you've got a deep interest in that. That's why you're here, in particular your workforce, but I'm sure for most of you in the whole health workforce, because what other professional colleagues and non-clinical colleagues are doing impacts on and can either make your work really good or not. And the other thing I just want to emphasise is continuing to strengthen the role of clinical leadership in the organisation. So down the back there is Andy Simpson, who's our Chief Medical Officer. I've just appointed and announced this week our new Chief Nursing Officer, Margaret Broodcorn, who's coming down from Northland District Health Board. Fabulous appointment there. Very lucky that good people put their hands up for that role. And a newly established role, a Chief Allied Health Professions Officer. Now, for most of you, you'll have seen this shift over the last decade of the the increasing role that the different allied health professions play in your work, and the leadership that has emerged at District Health Board level to support that. And so I felt it was timely we reflected that in the ministry, and so we have a clinical cluster that is led by those clinical professionals. The intention is that they work as a team and that they collectively oversee the deployment of our clinical expertise across our work in the organisation, but also supporting the work out in the sector. So I'm really pleased, and Martin Chadwick is the first and new Chief Allied Health Professions Officer, and Martin's been in that role at Counties Manukau until a couple of years ago, most recently at Bay of Plenty District Health Board, and he also chairs the national group of allied health leaders, so I'm really thrilled that he's going to be joining us as well. So just a couple of other thoughts before we perhaps open up for questions. I was reflecting on leadership. It's something I've mentioned, and what is the opportunity for leadership? And again, I'm interested in your thoughts around this idea of convene and collaborate. Now, that doesn't mean that we in the ministry don't sometimes have a role in providing quite clear direction as part of overall delivering for New Zealand. And I'm happy to step in where we need to into that, giving that more clear direction where it's needed, because very often the sector is looking for a decision to be made, and I won't resile from making decisions where they need to be made or from providing advice to the Minister about where he needs to make them. But for most of our work, we will be working and increasingly working with you, other professional colleagues, other health sector leaders, and the range of other stakeholders from both within the District Health Board, hospital setting, out in primary community care, non-government organisations, and of course increasingly with service users and consumers. That's another big opportunity. So I'd invite any thoughts or ideas you've got about how we might do that better. And I also want to that end, issue a specific invitation to you before I finish. And I want to just a little anecdote. I've shared this with Dave Gelly yesterday, but a couple of weeks ago I was at a meeting in Washington. Yes, I did fly economy class. And this was the Commonwealth Fund, which some of you may know is actually, despite the name, is a big US philanthropy, a very wealthy philanthropy that sponsors the Harkness Fellowships out of New Zealand each year, and we've had some fabulous Harkness Fellows out of New Zealand. And it also does an annual survey comparing health systems in different countries. It started from the perspective of comparing the US with Canada, New Zealand, Australia and the UK to try and point out the benefits of systems other than the US and what the US system might adopt from those countries like ours that have so-called socialised medicine. It's since extended to 11 countries and includes, amongst others, Sweden, Germany, the Netherlands, and one or two others are in the mix now as well. So at the meeting, and this is a very influential organisation, so we had actually the US Secretary of State for Health and Human Services came and opened on the opening night and spoke. And I was sitting between two Americans. On one side of me was Dr. Carolyn Clancy, and for those of you who've been around the sector and have been involved in quality or evidence-based medicine, she was for many years the leader of the Agency for Healthcare Research and Quality, ARC, so it's called. She's now heads Health and Veterans Affairs, so she's a long-term, medically trained originally, but long-time public servant. On the other side of me was a more recent appointment by the administration to the Department of Health and Human Services. So unlike New Zealand, the top couple of layers in the public service in the US are actually politically appointed. So a young fellow, I need to recall his name. Young, when I say young, he was younger than me, which means anywhere under age about 50. But he was essentially an entrepreneur. He came from a medical family, and he had one of his most recent venture had been to establish a nationwide home visiting service, in the home visiting primary care service, which had been very successful. So he had been brought in by the administration to head up the innovation area of health and human services, direct line to the Secretary of State, talks with Trump. So recent arrival from the private sector. Now, at one point in the evening, Caroline Clancy leaned across me and she said, to her US colleague, what was your biggest surprise? What surprised you most coming into your role? And he didn't miss a beat, and he said, the number of really smart, really hard-working people in the public service. And Carolyn Clancy smiled, and I just thought, snap, because I can tell you that is exactly the same for our Ministry of Health and our public service in New Zealand. So my invitation to you is, when you are considering your sabbatical, that you consider coming and spending it with us in the Ministry of Health. And the first person who is going to do this, actually, some of you may know, Dr. Pete Watson. He heads mental health services in Counties Manukau, at a really good time, because we're in the process over the next few months of developing up the government's response to the mental health and addiction inquiry, which the Minister received the report a couple of days ago. So Pete's coming in to join us for a few months early in the new year on his sabbatical. And in part that's fantastic for us, but I think it will be of immense benefit for Pete as well, because I know he would like to continue his leadership journey, and I trust that by spending some time in the core public service, that will assist him and support him to continue that journey. And I think it's just a rich opportunity. So I am inviting any of you, if you would like to, please do consider spending your sabbatical, or a part of it, with us in the Ministry of Health. We would welcome you, and we will engage you in our work, and I'm very confident that it won't take long till you form the same impression that the person did joining the Department of Health and Human Services in the USA. So I think I'll pause there, Murray, and I'm happy to leave plenty of time for questions, and I'm expecting a good grilling. Kia ora koutou.
Thanks very much, Ashley. I will open for questions very soon, but I wanted to pick up on three things. I've written three things down here: collaborative, clinical leadership, and the Workforce Directorate. So it's good to hear those sorts of principles coming through, and I think it'd be fair to say that ASMS is very keen to collaborate with the Ministry of Health and yourself whenever possible on these sorts of things like clinical leadership and workforce development.
Great.
Yeah.
Good.
Okay, questions? There's one over here, Lyndon Keane.
Hi Ashley, Lyndon Keane, ASMS. I think you probably agree that health workforce data is critical to good health workforce planning. But for quite a long time, the quality of that data has been left wanting, I think, highly variable. I think for the first time, a couple of years ago, for the first time, we started to see some really good data coming out of the Ministry on specialist workforce and the RMO workforce, including information on who was doing vocational registrations and who wasn't, and so on. It was very good data. A couple of weeks ago, I happened to get in touch with the Ministry to ask for an update of that data, and I was told, oh, well, this is the RMO data specifically, and I was told, oh, well, we don't do that anymore because the person who was doing it has left and we don't have a budget to replace him. Which I find quite despairing, really. So I just wanted to ask you, really, do you agree that good workforce data is critical, and can you ensure that the Ministry is going to be resourced to continue to try to produce good workforce data? Thank you.
Well, kia ora, Lyndon, good to see you, and it'd be pretty hard for me to disagree with it, your contention, but actually I wholeheartedly agree, and that is the rationale that was given that a person had been doing that but is now no longer there is one of the things that's driven me to establish the Workforce Directorate. I think that one of the frustrations for Health Workforce New Zealand has been that the resourcing of their work has been dependent on decisions made by the Ministry around whether roles were or weren't filled or backfilled. I think that particular area of work in terms of improving the data is one that they've delivered on very well over the last 8 years. I'm not so sure about some of the other things that they were set up to do, but that's a separate discussion. I think we can't do anything in terms of strategy, good planning and policy and commissioning appropriate training. Unless we've got really good data, it's fundamental. The other the other aspect of the current situation is that actually we have two different data collection efforts, one by the district health boards through TAS, Technical Advisory Services here in Wellington, and one by the ministry. And I don't know how much time they spend I was going to say arguing, debating the differences in the data, but for goodness sake, this should be a collective effort, and we are moving to do that. So it's one of the areas I will certainly be looking at. I did ask for some data to help inform my discussion today. I decided not to quote them, although I sometimes do, and that's about the increases in FTE we've seen in different professional groups over the last 8 to 9 years now. I know there are different views about what that's showing or not. However, if we don't have the data, we can't then have the discussions and then look at how we can improve it. So, yeah, I've got a really clear commitment. I'm very happy to state that here.
Hi, Sylvia Boyes. I'm an emergency physician at Counties Manukau, and I'm interested with your background in public health and thinking about those primary upstream derivatives of health, housing, education, transport. A lot of our health targets previously have related to issues that really relate more to those side of things, reducing child abuse, reducing rheumatic fever. And there hasn't been a lot of emphasis on making health a target for all departments. What do you think of that, and how can we move to having health as a whole of system target and keeping the responsibility outside just the downstream sector?
Great, thanks for that marvellous question. I could spend the rest of the question time responding to it because it's a huge area. I'll just make a couple of specific comments. First of all, you would have heard from the Minister yesterday, and he talked deliberately about a number of wider government initiatives that are specifically designed to address underlying factors that are also determinants of health around income, employment, housing, and so on. So that, clearly we've got a government that is intimately aware of what the impacts of those fundamental issues and determinants are on both health and other aspects of well-being. The second comment I would make is I think, and just picking up on the well-being framing of this, it's a helpful one from our perspective because we look at these things as determinants of health, but other areas of government look at them as determinants of other outcomes. And I think well-being is a good way to frame it because it absolutely encompasses good health outcomes, which are, from our perspective, of course, are fundamental to being able to live a long, happy life. So I think that well-being framing and the absolute commitment of this government to, and particularly the Minister of Finance, to this next budget being a well-being budget and wanting to see initiatives that are connected across government. And one area, and you mentioned it, family violence, sexual violence, which is an area I'm sure none of us disagree we need to do much better at. So we've now got a joint venture being put together that is going up to government, which the chief executives of a number of agencies, chaired by the State Services Commissioner, Peter Hughes, are accountable for as a board. So I think we're seeing movement in that direction. So yeah, a couple of thoughts there. I feel optimistic about our ability to both influence and to make progress. And my final comment is, this will be fundamental to us being able to improve equity in the populations, because we know that the populations who currently have the worst health outcomes, Māori, Pacific, low-income New Zealanders, are the ones whose profile is worst in terms of those determinants. Final comment, because I can't not say it. For those groups, I think that is actually where the health sector has an even greater role to play, because if we deliver services in a way that is accessible and very mindful of the needs of those people as they go through our system, then we can actually mitigate some of those underlying determinants. But that requires quite a deliberate effort on our part, and I think it's patchy at the moment. I think we've got some good examples, but we need to be a lot more consistent and do better.
Brian Craig. Let's remind people before they ask questions to say who they are and where they're from.
Brian Craig, a psychiatrist from Canterbury. Look, thank you very much, Ashley, for your response to Lyndon's question, I think, about the data gathering. It's good to hear that I think that's going to be resourced properly. I mean, I have a question that's connected with that, and I think you've probably partially answered it to some extent. But when the New Zealand Workforce New Zealand, Health Workforce New Zealand was set up under the the Public Health and Disability Act in 2000. I think we all had some hopes that that was kind of going to lead somewhere. It was under the chairmanship, I think, at the time of Prof. Des Gorman. But over time, it appears to many of us, and I think probably a lot of my colleagues would agree with me, that it does not seem to have delivered. And I think you've partially answered that around questions of resourcing. My understanding now is that that is absorbed into the ministry. And I mean, is it going to be properly resourced? And do you think it's got more chance of delivering than it has until now? That is, of course, if you agree that it hasn't delivered. That's my question.
Right. Kia ora, Brian. Yeah, look, I'll make a couple of comments there. I think that Health Workforce New Zealand has not delivered everything it was set up to do, and some of the reason for that is because of the way the arrangements were, that actually you had an organisation that was set up that had both dual executive and governance functions. So it made decisions, and in particular the chair's role was set up to make decisions around how money flowed, but it was also reliant on its secretariat and the support and the sort of the management of the money being in the Ministry of Health, and the two didn't always align, and I think that that hasn't served the sector well. I have views on some other reasons why perhaps it might not have delivered all it was set up to do. So what I'm saying with the establishment of the Health Workforce Directorate is I am happy to work with the sector to lead and be accountable for improving our strategy, our policy, commissioning, delivery of a well-trained workforce that is fit for the future in New Zealand. I'm happy to be accountable for that. I need support to do that, and I'm very keen to have to retain Health Workforce New Zealand but in a really strong governance and monitoring role. And I think that clarity of functions will serve us better, and clarity of accountability. So that's what I've done with the establishment of that directorate.
See, the next person I had was Siobhan over here. I'll come back. I'll come back. Okay.
Hi, I'm Siobhan Cross from Canterbury. So I'm from a DHB that has one or two building projects going on at the moment. Yes. And we were listening to the Minister yesterday about the asset management plan and strategy going forward, which is fantastic. But things like leaky buildings actually also come from a lack of investment at the time, and then you end up with mistakes. And so it's all very well saying this building should last for 50 years, but if you don't invest the money at the time, then you run the risk that it won't. And we see that quite a lot, and I'd like your comments about those concerns.
Yeah, sure. Kia ora. And as I say, I was down in Canterbury just last Friday, and a month or two back had a tour around the new acute services block. I don't think any of us can wait till that's built and finished. Unfortunately, it's late, but it will be a fantastic building. So yes, you've identified, and the Minister spoke about this at some length yesterday. At the moment, I think we've got this this sort of perfect storm of three things. One is we have quite a number of our buildings around just about every DHB in the country coming to or near end of life. And some of them are quite big buildings. They're the ward blocks. There are many DHBs around the country, and I dare say one was the one I was chief executive of at the Hut, where the main ward block, for a number of reasons, will need to be replaced in the next wee while. The second is all DHBs have now got seismic assessments of all their buildings, and some of those are a little bit sort of interesting. However, they don't necessarily need immediate action, but they do require action. And the third thing is, and you've alluded to this, is in part because of the quite constrained funding environment over the last 5 or 6 years following the global financial crisis, and the Minister referred to the percentage of our public funding of health funding, the percentage of GDP has declined slightly, which is actually unique amongst the 11 countries. We're at the Commonwealth Fund meeting a couple of weeks ago because they showed a slide on this. And so the way, of course, then to continue to ensure you deliver your services you need to deliver is you reduce your depreciation budget. Then, of course, you don't do the maintenance that you need to do. So we've also got this quite big backlog of deferred maintenance, and some of that deferred maintenance, is required because, as you've identified, some of the building was not done that well in the first place, including on some quite recently built buildings. And for example, the issue at Capelin Coast with their copper pipes right through that main new building that was only opened 6 or 7 years ago. So we have some real challenges to deal with. The key point here is, as we plan new facilities for the future, we do need to take a longer term view rather than just focusing on value management to get within a certain capital budget. But think, well, if this building is here for, and it shouldn't just be for the next 30 years, we should be building them so that they can be adapted over a 50 or 60 year period. The building I felt happiest about at the Hut was where my office was, in the old nurses' home built in 1942. I dare say it was not a particularly salubrious office. My brother came in one day and he said, well, you can hardly be accused of wasting public money on flash executive offices. But, you know, really solid building, and the main clock tower block as well at the Hut is very, very solid and has a very good earthquake rating. Some of the newer buildings, even from 20 years ago, are the ones that have got the problems. So we need to take this longer term view, and that goes to the heart of that stewardship function. It's not just about value management today to live within a budget, it's thinking about the long term.
Hi, thank you. My name's Helen Moore, I'm a radiologist from Auckland, and I'd like to kind of sneak in a couple of questions, but they overlap very much with what has already been said. Firstly, in terms of the buildings, with the long-term view, etc., is that going to be specifically with a green element, sustainability, you know, all the cost benefits associated with that? I was just wondering whether that was going to be formally recognised as part of the building asset planning that, you know, David Clark was mentioning yesterday and what you've been talking about now. So that was one specific question. And the other one was the crossover with the data questions before, not just in relation to workforce planning, which is obviously essential and very relevant to all of us here, but in our different work streams, and as a radiologist I cross over with lots of different clinical groups, it seems we have great ideas, we have enthusiasm despite great odds often, and it comes to a point where you actually cannot progress a whole lot of stuff because you do not have the IT infrastructure, and particularly I'm talking about IT. And a few years ago we had a person here, I don't remember his name or title, but he was kind of like the IT Superman from the ministry, talking about sort of an IT national solution, which makes a lot of sense, but nothing, I understand, has happened. And particularly now, for example, with bowel cancer screening, measuring standards for tumour. We don't even have staging data for cancers in New Zealand like other countries do. And in terms of just even stuff from primary care and prevention and vaccination rates, etc., we don't have a unified way of doing that across New Zealand, and it creates so much more extra work. So an investment up front in an IT which would hopefully be common to all of us and able to be shared and able to be future-proofed, it seems to be something that's just too hard. And I would really be delighted with some leadership in that area because lots of people have been talking about it for a long time. So forgive my two questions being in there, but there. Thank you.
Perfect, thanks. I mean, two really good questions. So just in terms of sustainability, yes, the sustainability green aspects of new build are very much on the table, not least because one of our associate ministers, Julianne Genter, from the Greens, and so this is something, there was an expectation in the letter of expectations to district health boards this year, which was around efforts around sustainability, reducing their carbon footprint, and your colleague from Counties Manukau, I think Dave Geller, was very influential in perhaps supporting that and the work that's happened subsequently. So there's an increasing focus on that. I think that's good. It does add cost into new builds, and so that's something that, again, we have to have a longer term view about, but it is very much on the table. And for example, in the work on Dunedin and essentially a whole new hospital campus there, that it's one of the factors that's been discussed. In terms of your other question, if you can remember the name of the Superman, let me know. I'm still looking for the person. Well, maybe I'm not looking for the person who's got the solution to our IT challenges. A couple of comments, because again, it's something we could talk at length about. I think we have plenty of vision in this area. Our challenge is in execution, and that's not unusual to the health sector in this area. It's not unusual to Aotearoa, New Zealand. The way we're thinking about this now, just before I came in, the Ministry had commissioned and got at Cabinet's request, at what was called an indicative business case about to go to an electronic health record. We've changed tack on that slightly. I think we all know what we mean by an electronic health record, but what it's not is a record that is digitised. And the second thing is that countries that have gone down an electronic health record type pathway have tended to go to and become reliant on a single proprietary product, and the experience has not been good. So we're just reframing that in two parts of that. The first is, whatever you do in this area needs to be deeply driven by and linked to your overall strategy. It's not a thing in and of itself that is a good thing. It can be good, but it needs to be right. This is the direction we want to go, and here are the investments we need to make in data and digital to support that, to support care closer to home, to empower patients to look after their own health, to do more in the community, to ensure our specialist providers are able to access the data they need when they need it at the clinical interface or for service planning. So we're talking now about this idea of a national health information platform, because the challenge here, and there are plenty of examples of where this is done successfully. I'll give the example that former CIO were my previous role at Cap Coast and Hutt, Shane Hunter used. Uber all it does is pull data from existing databases and puts them together in a new interface to deliver a profoundly different, disruptive, but also extremely helpful, useful service. So the challenge here is to chart out a pathway, as you're saying, leadership, yes, ensuring direction. Here is the pathway, here is the investment that will be required, and start relatively modestly, because the last thing you want to do is go to Cabinet and say, we've got the answer, and it's only going to cost $350 million, which was the preferred option in the first draft of the paper I saw. Well, you know that's not going to go very far. What we need to do is start modestly, do some things, start to link up, start to build the health information platform, be happy to fail a bit, and also be able to adapt, because the world is changing so fast in this area. There are new things coming along every 6 to 12 months, so we need to be able to adapt as we go. But yes, we're happy again to show leadership. One of the new directorates is data and digital. I'm looking for the Superman or woman to lead that at the moment. Got some great applicants, and we're happy to work with the sector on this and ensure that the investments we do make actually deliver real value and benefit.
Hi, Jenny Henry Anaesthetics in Northland. You've touched on sustainability in buildings, and my question to you is, we're shocking producers of landfill and waste and carbon gases, and I would really be grateful to see much more of a drive in the health sector to make it easier to reduce that, recycle, because every day we're just filling up the plastic bags with rubbish, and it's really hard to kind of do it. And so I think as a massive organisation in New Zealand, it would be really good to actually be driving that. Yep. And I'd like to hear, how, if you think about this and what you would do to it.
Yeah, thanks, Jenny. Really good point. And yes, in pretty much every DHB in the country, the District Health Board is the largest organisation and the largest employer in there, Rohe. So, I've alluded to the expectations that were on DHBs this year, and there is, I know, there are some leaders amongst you here and outside of this room who in each DHB are really driving and leading efforts to do this work. The expectation this year was DHBs come up with a plan of how they're going to ensure they understand, if they can, what their carbon footprint is, what they are doing at the moment to address issues around reducing waste, to address that. We've got a person in the ministry, Dr. Richard Jane. He's actually a public health doc who's leading the work from where we are. We've canvassed what's happening right across the sector, and the minister has now asked us, actually it was James Shaw who was filling in for Julianne Genter, so again, a really strong focus on this, asked us to come up with a plan that actually then looks out over the next year or two as to how we're going to work with the sector to address exactly these issues, improving, reducing greenhouse gas emissions, reducing waste, reducing our carbon footprint. And our job is, again, to convene and collaborate, facilitate sharing of ideas. So it's absolutely on our work program.
Hi, John James from Dunedin. Another question about hospitals and buildings, I'm afraid. Because we all work in hospitals, most of our members, and so hospitals are important for us. So we're building a new hospital in Dunedin, and we're at a very critical phase because we're deciding the size of the hospital, what should be in it. And I've been to about 150 hours of meetings about our new hospital. And in the planning process, external experts were engaged by the ministry, and they did lots of accurate projections about our projected need over the next 20, 30, 40 years. And then there was a process of top slicing, or correction. For example, in acute medicine, the number of beds have been reduced by 30% because of presumed new models of care that will evolve that will mean that people won't be in hospital anymore in 10 years, 20 years. I suppose, what if those projections are wrong, or that top slicing process has been inaccurate, and the new hospital is too small within a month of opening? Or if those new models of care do develop, who's going to pay for it all?
Well, you took the Minister's comments to heart, didn't you, yesterday? Thanks for that one. Look, I don't know the detail, although I'm aware of the process that's happening in Dunedin. What I will say is I share the aspiration to reduce acute admissions to hospital by 30% now and into the future, and I think we can and should be looking for ways we can do that, and I think we've got some examples of that point us in that direction. I think this goes to the heart of how we then design and build these facilities so that there is the opportunity to expand capacity into the future as required. And the way someone described this to me is we should be thinking about how to build much more, for the base part of a building, we should be thinking, how do you build that quite generically, the solid part of the building, with the ability to shift it around and change inside over the life course of the building, and also develop extra capacity as and when needed. I think, just one comment I think that is pertinent here. Of course, I've come from a public health background, so I'm a great believer in prevention, and I also strongly believe in good primary care. But even if you do all those things, that doesn't necessarily reduce demand for specialised services. In fact, it may increase it because you may uncover unmet need. And so there's a sort of it's a bit like the aphorism, prevention is better than cure. I don't think we disagree with it. However, it's a bit more complex than that, and I think it's the same in this space. The challenge and the opportunity here is to think, how do we use our specialist ability, capacity to support excellent delivery of care and management of chronic conditions in different ways? And I think that's the opportunity around models of care, so that we can, and we should be looking to minimise admission to hospital. And I think this is particularly important for our older population, for our frail older population. I think we all agree that hospitals are not the best place for these people. And there are a lot of admissions that we can and should avoid if we have the right services available to wrap around, support people when they might even be in quite acutely unwell, but we can actually deliver care for them in different ways and in different settings.
This will have to be the last question.
Okay, all right.
I'll take another. I'll take one unless you're on time, because I'll be happy to answer Tony's question as well. Yeah.
Okay, so I'm Julian Vice. I work up at Starship. Slightly different tack. So you talked about collaboration, you talked about avoiding a command and control culture and whatever, and I think those are great things. We'd all endorse those. I think the reality, from conversations I have locally and with colleagues around the country, is that doesn't necessarily happen at the shop floor level. Yeah. And decisions are made, decisions presented as a fait accompli. Engagement hasn't happened, even though they're enshrined in various meccas for us, NZNO and things. So stuff like that still goes on. So what would you suggest to people here or people live streaming? How can we get past that sticking point of being just given a decision by decree? And how can we ensure that we're part of the thing to get a better outcome for the health service that's being provided by that decision?
Yeah, another million-dollar question, that one. Look, I think that's just something we all need to work on. It's an expectation I've created in my organisation. The other challenge here can often be you might have agreement or a way of working amongst the senior leaders in an organisation, but when it filters down to the tier 3 and 4 managers. Peter Hughes describes this as the wall of no at middle management. So part of that is how the leaders of the organisations empower and support managers to make decisions and in the right way. I mean, it's not necessarily answering the question, but it's a point that I think is pertinent, and it's about leadership and about how we train our clinical and non-clinical leaders. And I think this is something that we would get an enormous return on an investment in training our clinical and non-clinical leaders in our sector. So from where I sit, what I'm thinking about is where's the next cohort of organisational leaders, and there will be people out there in this sector who are both aspiring to and have the capability of being excellent leaders in our healthcare system, and they'll be from both clinical and non-clinical backgrounds. What's the cohort of 100 people who are, in early mid-career, who we can actually identify and nurture and quite deliberately train and expose to different experiences, including perhaps spending their sabbatical in the ministry for 3 months to give them exposure to that environment. So I think it's an investment in that leadership will address, amongst other things, address the sort of challenge that you're identifying. Tanya.
Kia ora, Ashley.
Kia ora.
It's lovely to see you in your new role.
Yeah.
I have 2 questions. I guess I feel like the elephant in the room is that instead of the leaky, mouldy buildings, we potentially are the leaky, mouldy clinical workforce, and clearly Charlie's work on burnout. I mean, I think that's a really... I was very surprised to find out about that. I guess I would be really keen, because there are 50% of us that are just hanging on by our fingernails here, what we can expect to be the thinking in the ministry for how that may be resolved. Yeah. Broad brushstrokes. I know that the review with Heather Simpson's coming up, but for those of us that are feeling burnt out, it would be great to kind of have a flavour of what that might look for. And also, I'd be interested. I wasn't at the ASMS conference last year, but I was the year before when there was a different Minister of Health, and I'd be interested to know, or have your reflection on perhaps the kind of change of flavour.
Thanks, Tanya. Okay, I'll try and be quick because I know you've got a program to get on with. So, look, the first issue you raised, and I had a look through the latest specialist and have heard about the research around, in particular, the impact of that burnout for our female senior doctors in their 30s to 40s, and I think you had a bit of more of a discussion about that yesterday, as well as some of the gender pay differences and so on. What I can state is a really strong commitment to addressing those issues, and I think they are apparent, and you have good research in this workforce, and that's good because it provides a platform for us to then act collectively. However, I think it's also an issue in other health workforces, and so we need to look at this in the round. So absolutely committed to it. I think it has to be part of our work we do on workforce. And I don't have any clever ideas on this. I think it's going to require us all to really put our ideas together and probably work differently. And that goes also to the heart of it. Should be something we take into account as we develop new models of care. Actually, how do we work differently? So one of the things the Minister mentioned yesterday, and there may well be differing views on whether I should or shouldn't be doing it and who's around the table, but I am interested in convening a group to think about and identify in the first instance what are some of these specific challenges for the medical workforce, both training and senior workforce, so the RMO and SMO workforce, and how do we collectively then be quite deliberate about addressing them, because I think it will require a sort of a whole package of initiatives. What I don't think is that we can nor should address it through an industrial negotiation. I think it requires a whole lot of players to really be thinking about it, and it's about how we train people, how we deliver healthcare services, the expectations we have on each other, and then how we, again, strengthen that leadership, that co-leadership of our service delivery, clinical and non-clinical. And then what's changed? So I'll probably just go back to the set of priorities that the ministers and the government has put up. I think that's a different flavour. I think what's also evident to me from my previous role as a chief executive is we've got a minister who is probably more engaged with the sector than the previous minister was. And that's a good thing, and it's certainly the way we want to work, so there's a good alignment there. And I think, one thing I will point out is that this government's come in, and the Minister talked about it at length yesterday, with a strong commitment a clear commitment to investing in the public health sector. And you guys will all have a role, people will all have a role in ensuring that the government keeps hearing the message that investment is needed, and your ideas for good value investment, because I think with investment we could make we could really shift the system. It will require investment, I've no doubt about that, but we need to make sure it's the right investment to get what we're looking for.
Thanks very much, Ashley.